Okay, we are live.
Great. Welcome, everybody, to our COVID-19 Concerns with Children meeting. My name is Andrea Garcia. I am the Chief People Officer here at Cadengo. So we are very, very excited to have you here today and to also have our guest speaker, Dr. Tina Sebastian, who's going to be presenting on COVID, the vaccine, and we'll be able to take many of your questions this evening. So before I go ahead and start, I want to also give you a rundown of what today will look like. So our meeting goes for an hour and a half. We will conclude at 8 p.m. We will have the presentation from Dr. Sebastian. We will then go ahead and have our very own Julia Nazareno, who was one of our center directors, who will be sharing her experience about being vaccinated. And then we'll go and open it up to questions and answers. Now, if we have time towards the end of our session, we'll go ahead and be answering any questions that you may have related specifically to Cadengo's procedures and processes related to COVID-19. So the meeting will primarily be in English today. However, we will be taking questions in Spanish at the Q&A. And I will be translating just a little bit, so I ask our English speakers to please have a little bit of patience with me as I will be doing my best. So, bienvenidos esta tarde a esta junta que tenemos hoy con la doctora Tina Sebastian, que nos va a dar una presentación hoy sobre el COVID-19 y cómo les afecta a los niños. Mi nombre es Andrea García y soy la directora del personal aquí en la agencia y estamos muy agradecidos de que nos puedan estar con nosotros hoy. La junta primordialmente va a ser en inglés. Al final vamos a tener más o menos unos 45 minutos para tener preguntas y respuestas. Si gustan esperar y hacer sus preguntas en español, no hay ningún problema, podemos traducir. La doctora Sebastián también habla español. Si prefieren recibir la grabación de esta junta en español, también pueden hacerlo. Esperemos que la conversación la junta va a estar traducida más o menos en una semana y media. Así es que tienen opciones, pueden compartir la hora y media con nosotros hoy, o si prefieren recibir la grabación traducida en español, también son bienvenidos. La doctora Sebastián va a presentar por más o menos media hora. Después vamos a tener una de nuestras directoras del centro, Julia Nazareno, que va a compartir con nosotros su experiencia al recibir la vacuna. Y luego vamos a concluir con la sección de preguntas y respuestas. Okay. So we again are very excited to have Dr. Tina Sebastian. Dr. Tina is a pediatrician with a master's degree in public health and has been practicing medicine both in clinical and public settings for 15 years. Her work has taken her internationally, where she has lived and worked in Eswatini and Mozambique for 9 years in pediatric HIV. She currently lives with her family in Denver, Colorado, where she splits her time working in an urgent care and as a clinical investigator in pediatric research of various infectious diseases, including COVID-19. Okay. We also, as I mentioned, have Julia Nazareno, who's going to be also sharing her experience. Como mencioné, la doctora Sebastián va a estar dándonos nuestra presentación. Ella tiene su maestría en salud pública y ha estado practicando la medicina por 15 años. La doctora ahorita vive en Colorado con su familia, donde ella trabaja en una clínica de urgencia y también como una investigadora de clínica pediatra, incluyendo el COVID-19. So with that, again, I'd like to introduce you, Dr. Tina Sebastian.
Hi, everybody. Good evening. I'm going to share my screen.
so we can see. Let me know if you have any problem seeing my screen. Thumbs up. Great. Thank you. Thanks for this opportunity. It's such an honor to be here talking to you guys. I have a long history with Kadango, actually, because so my mom had worked with Kadango for over 30 years until her retirement, and I taught for Kadango for a period of time. My sister attended Kadango from like I don't know, 2 months of age through preschool. My daughter attended Kanango for a while, so it's actually quite exciting to come back after so long, and give back to this great community. So thank you for that. Today I'm gonna talk about COVID-19. We're gonna go over a bit the overview of disease, infection, vaccines, but obviously with a look at children and what's happening in the pediatric world with it. I hope that the fact that I'm a pediatrician helps with a lot of these questions. I know there's been a whole lot of myths and misconceptions out there, so I really would like to focus a lot on that too. But I will talk a bit about science. Feel free to ask questions at the end. So we're going to go over just a few statistics, nothing too big, but just so you get a better sense of what's happening around the US. We'll talk a bit about how infection is spread. We'll look at how do adults and children differ? What are some of the keys to protecting ourselves? How does this all translate for schools and learning in person? We'll talk a bit about herd immunity. I will go over the 2 vaccines that are currently approved in the US. We'll talk a bit about why many people are hesitant to get the vaccine, what I can do to help kind of talk people through that hesitancy or at least start the conversation. And we'll talk a bit about equity. So coronavirus disease 2019, that is the long way to say COVID-19. We know that this was kind of came out of the blue in December of 2019 when the WHO started reporting clusters of cases in Wuhan, China. And then they announced in early January that it was caused by a novel virus, which means it was a virus that had never been seen before in our current day. As of February 11th in the US, we have more than 27 million cases, which makes about 25% of the cases in the world. Just to note, the US is really small in terms of population of the world. It's only 4%, but we carry 25% of the COVID cases. At this point, we have over 470,000 deaths. I think today was close to 490,000 actually, total US deaths as a result of COVID-19, which is about 20% of the deaths in the world. We have about 3 million cases in children in the US, which make about 13% of the total number of cases. And that to think about children in the US make about 22% of the population. So actually we have even less children that are testing positive than we expect, and very, very few pediatric deaths in the US, which is, one little shining star in this. We do know COVID has a very disproportionate effect on certain populations. And I'm sure you have heard of this, that we have more COVID-19 infections, hospitalizations, and deaths occurring in communities of color, especially Black, Hispanic, Latinx, and Native American populations. Hispanic ethnicity and Black race are actually associated with increased risk of hospitalization and ICU admission among children as well. And there are a lot of factors that contribute to this increased risk. We talk about systemic racism, discrimination, access to health care, utilizing it, which means going in to be seen, having your well child checkups, your yearly physicals, what type of occupation you have. So if there are more essential workers in your community, you are at an increased risk, obviously, of exposure to COVID-19. Educational income, wealth gaps. We do know that communities of lower income have less access to many things, including healthcare, including often having higher health comorbidities like high blood pressure and heart problems and diabetes. Housing can be a huge issue. In many lower income communities, we have crowding, so higher density of people in smaller space, and we know that that can increase risk of getting COVID. If one person in a crowded space has COVID infection, their chance of exposing others and spreading the disease is much higher. In general, we're doing better in the U.S., right, than we were, let's say, in November and December in terms of our epidemic, but we're still not in a good place. So we still have a whole lot more work to do to get the epidemic under control in the US. How does it spread? I'm not going to go into too many details. You'll have all this for you guys, but we know they're both respiratory and airborne transmission. What does that mean in simple terms? When you cough, sneeze, talk, sing, laugh, like your droplets come out, and essentially on average they go about no further than 6 feet. This is where the 6 feet distancing rule came from. So COVID is transmitted in these respiratory droplets. Sometimes those droplets can fall onto surfaces as well. So you can touch a surface that has these droplets, and then if you touch your face, your mouth, your eyes, that's another way that COVID is spread. And then, as you know, it can hang out in the air. And that's one of the more worrisome ways, because that you can't see. And if you are in a poorly ventilated space that's enclosed, so a closed room with no ventilation, it doesn't matter that a person with COVID left the room. They could have, the particles could still remain in the room sometimes for minutes to hours after they have left, putting other people at risk when they enter that space. So that's kind of the way that it's spread. COVID's pretty contagious. It's not as contagious as measles, but it's more contagious than our routine flu. So it's something to think about, how we came up with measures to prevent spreading COVID. So how does the infection then occur? Some people think that like you get one virus into your body, and then maybe that means you're already infected. And the truth of it is that you're not infected with disease just based on one particle. People don't really know how many you need. So there are studies out there that say people that have immune system problems are not as healthy may require less viral particles to kind of come in your body to be infected, whereas healthy young people may need more. That debate goes on, but the clear answer is the more virus particles get in, the more likely you will get infected. And the main target for coronavirus is the cells that line the lungs. And that's part of the reason you hear so many people talking about respiratory issues, breathing, coughing, all of that being such a huge part of COVID illness for so many people. And what happens is once this virus kind of locks onto that cell, it's so smart, it goes into the cell's machinery. It tells the cell, now you're going to make more virus, and it just basically hijacks it. And now the cell becomes this reproductive factory of just making more and more virus. And because this is a novel virus, like I mentioned earlier, meaning we have never ever seen this before, our bodies are not prepared. We do not have an immune system that's ready to fight it, because we've never seen it before. So there is some time that passes before most healthy bodies start to have an immune system response. And what that means is our body finally starts to see these particles that are not normally a part of our body, and it starts to create soldiers, which we call antibodies, to fight that infection. And they also create cells that remember the infection. So that's kind of how the immune system starts to mount this response. And the amazing part about it is that it'll remember. A lot of people can get sick during this time when the immune system starts to really amp up its activity. So that's when you get the fevers. that's when you get all that mucus and the runny nose and the cough. That's a serious sign of your immune system starting to fight. Infection means you have COVID, coronavirus in your body, but that doesn't mean you get sick. Disease is when you start to manifest symptoms. So there's a very important difference between infection and disease. And I also think about it like asymptomatic versus symptomatic. So infection could mean you are asymptomatic and you have no idea you have anything. Once you become symptomatic, that is when we know you have coronavirus disease. Many people ask, like, then what happens? How come some people get such terrible sickness, and what causes that? And what really happens is that we don't know why some people have the issue and others don't. I mean, we do know that certain people are at higher risk, like people with high blood pressure and the people that are have problems with obesity, diabetes. That population could have higher risk for having complications, but that has a lot to do with the fact that they are not as strong as those whose immune systems don't have this chronic disease. But there are plenty of people in the world that have no existing conditions that are healthy that have terrible complications. Again, it's rare, but it happens. And I think what is becoming more and more clear is that in our body, once our immune system starts to mount this defense and start fighting, some people's bodies kind of go overboard. They go way out of control, and the immune system just gets really, really, really revved up, high inflammation and all over. It can start at the lungs, but sometimes it gets so bad that it's all your entire body. And that's when you have people going into organ failure, and like your systems are not functioning because all they're doing is ramping up to fight, to fight, to fight, and they aren't then doing their normal function like they're supposed to. What are the differences we see between adults and children in terms of COVID-19? Adults that are older, we talked about this, that have the high risk conditions, they are higher risk. On average, kids, they're both less likely to be infected and they're less likely to become very ill. I showed you the data showing that we don't have that many deaths in children, which is great. But also why? That begs us the question, why are children not as affected? In general, when we have respiratory illnesses, think about the flu, think about colds, think about any sort of viral like throat infection. I mean, kids have them up and down. They're always sick. I am sure all of you can attest to this. So, why was COVID different? That is actually a good question, and a question we don't have a clear answer to. People are trying to study it. There are a lot of theories behind it that maybe we'll get into later, but we still do not have a clear answer why. We do know that children that are much younger, like infants, those are that less than 1 year of age, do have a slightly higher risk of severe illness. That you can attest because their immune systems are not as strong as older children or adults. We also know that kids can transmit to household contacts. I'll talk about that a little bit later in one of the slides, but the exact proportion of transmission, that's still a bit clear. And finally, we are hearing a lot about this very rare but very critical and scary illness called multi-system inflammatory syndrome in children, MISC. I'm sure you've seen the news reports about it, and it's a condition that can make children that have had a history of COVID, and it's usually children that have had a history of COVID, like in the past, maybe 1 to 2 months before, they can become very sick very quickly and require hospitalization and maybe even ICU stays. And the prevalence, in general, between males and females are pretty equal, though males have shown to have higher mortality, which means higher risk of death, especially in adults. And it's very important that we remember that most of the cases of COVID that are being spread are asymptomatic cases, meaning they have no sign of infection, almost 60%. So that's a pretty scary statistic and scary thought. But again, this is why we are trying to do so much of the measures of prevention that we're going to get into. like right now. So how do you protect yourselves? And I loved this little slogan that people came up with called "Practice Safe Six," and essentially it's everything you already know and have heard a million times, and I'll just put it in one slide. So stay 6 feet away, wear your mask as much as you can with anybody outside your household, wash your hands often. If you are at risk, any of those categories we've already talked about, be extra safe. You want to stay home when you're sick, don't expose others, and then get tested if you have symptoms. Testing remains the key strategy for us to really understand how this epidemic is going. So, the importance of schools, where do we go from here? We know, I mean, nobody is doubting how important schools are to the infrastructure of every single community globally. Not only do they provide safe and supporting learning environments for students, you employ teachers, other staff, but schools also provide really critical services like meal programs, social, physical, behavioral, mental health services. Now that it's been almost a year without in person school as a regular part of life, I think people are realizing just how amazing and critical schools have always been to the fabric of our society. There's also indirect benefits to the community, including enabling parents and guardians and caregivers to work. But opening schools in the middle of the pandemic, I mean, led to the most basic and most important question: will this lead to more transmission of COVID-19 in children and educators and staff of schools? There have been a lot of household transmission studies that have been done where people are looking at, are children the first people infected in the house and then they transmit the infection to other members, or are other members the first and then they give it to the child, or is it the same time, and can we tell, and what is all the science showing? And it's, there's a lot of data and there's a lot of unclear. I mean, I'll just say that there's some studies that show kids are equally at risk for transmitting as adults. Some studies showing that children less than 10 are much less likely to transmit to others than adults. And I think that overall arching theme, including what the CDC is saying, the American Academy of Pediatrics, which is the main body for pediatricians in the country in terms of medical groups, professional groups, we're sticking with, we do at this point believe that children less than 10 do have a lower risk of transmission than adults, and the older than 10 group is still unclear. And you have to put this into the context that, like I said, children in general are having very mild or asymptomatic, meaning no symptoms, when they get infected. So then they're not getting tested. If I don't have symptoms, why would I get tested? So we're probably not truly understanding how many children are getting COVID, but we do know they're not getting that sick. But this makes the question of transmission from child to adult then a very difficult question. So if you didn't test the child, then it appears like the child was negative. Is that true or not true? And that can be a tricky question. So what does this mean for in-person learning? We do know there have been outbreaks that have occurred in schools leading to closures, and there is significant secondary transmission, which means that a child or an educator will pass the COVID infection from them to another person in their classroom or in their, vicinity at school, if this happens, if mitigation strategies are not implemented or followed. What does that translate to? We do not wear our masks well. We do not have safe distancing at school. We are not cleaning like we are meant to be. We are not ventilating the space, the air, like we're meant to do. So when those things are not happening, we are definitely seeing transmission of COVID. But of course we would. Like I just went through how it's spread and how it is transmitted. So if we're not doing the safety protocols, well, then it makes sense that even in schools and even children can transmit. But when we are doing these mitigation strategies, these prevention strategies, then we are seeing a very, very low transmission in schools, and especially elementary schools or below. There's still a lot of debate about middle schools and high schools based on the age of children. But the overwhelming evidence shows that in-person learning at schools is not really driving the COVID epidemic. What they're seeing is if community transmission is going up, well, then pediatric transmission goes up. But just because schools open doesn't mean that pediatric transmission then goes up even higher because the schools open. They are running very parallel, which makes you feel more comfortable that schools are not a huge source for new infections for children or educators. And again, though, I will say this is always when we are doing our prevention strategies well in school. Reducing the transmission in schools is a shared responsibility. This is a critical message for this presentation. We have to remember that if community transmission is high, there will be increased transmissions in schools and it won't be safe. So we just have to kind of think about all of that. If community transmission is high and we are able to do our prevention strategies well, then in-person learning is possible. But there's a lot of factors that play into all of this. So how do we move forward? There's a lot of talk about herd immunity because that's essentially the most important part about kind of moving through the pandemic. We have to get people's bodies ready to fight this infection. And how do you do it? There are two ways. One is naturally by you, unfortunately, getting COVID infection, and then your body naturally makes antibodies, the soldiers, to be able to fight. Or two, you get the vaccine, and the vaccine, and we'll go over this in a couple of slides, how the vaccine pushes your body to make those same antibodies. So there's both mechanisms are the same. Your body makes soldiers to fight infection. It's how you get to there that that's different. And a lot of people kind of speak about, why don't we just let the infection run wild? Why can't we do all this naturally? And then we'll have immunity. But one of the biggest problems with that approach is that one, it will take a really long time to get 70% of the population to get COVID infection. I think at this point, most people think that even less than 30% of the world has been infected. So, and that's after like almost a year, right? And it's an interesting thing to think about. How do we get to 70%? How long would that take? And then the reality is that the collateral damage is going to be so high. Too many people dying, too many people having healthcare complications. That would be so horrific. And is that ethically right? That doesn't seem fair or good. And we know that this infection affects vulnerable communities disproportionately. So there is no justice there to just say, well, too bad for them. So I think that's why science has really moved and pushed for vaccines, because in scientific terms, it is the fastest and safest way to achieve global immunity. So, what are the benefits of getting the COVID-19 vaccine? We prevent people from getting COVID-19 or becoming seriously ill or dying due to COVID-19. We prevent spreading the virus to others. We basically add to the number in the community of people who are protected, making it harder for the disease to spread. And that is the most important way that we achieve herd immunity. And then, the less COVID viruses out there, the less chance that the virus mutates. Every single virus will mutate if it has free reign. If more and more people are affected, viruses are really smart. They will adapt and change. So the less virus, the less likelihood of mutant variants. The more virus, the more likelihood. So that's why we're in this critical race right now to get more and more people vaccinated so that we don't have more infection. This is going to be very difficult globally. As we know, so many countries do not have adequate access to vaccine. We're struggling in the United States. So imagine the rest of the world in many places. There are currently two approved vaccines in the United States, Pfizer and Moderna. They're both mRNA vaccines, and we'll kind of go a little bit over what that means. They both need to be frozen. Pfizer needs a really, really special freezer, whereas Moderna doesn't need that special type of freezer. Pfizer is approved in the United States. This is emergency approval, of course, but for children and adults above 16 years of age, and Moderna is approved for those above 18 years of age. They are both 2 doses. They are effective across gender and race, and they are up to 95%. They have 95% efficacy. Both of the latest trials for both Pfizer and Moderna included more than 30,000 participants, which is wonderful. Wonderful that they were able to enroll so many people so that we have a better sense of what happens to a larger community that is exposed to the vaccine. In general, historically, people of color were always underrepresented in clinical trials. Most clinical trials, have been done on the white population. But both of these vaccine trials did try really hard to have better representation of communities of color. It's still not equal to the proportion in the population, but still both of these trials did really a much better job of enrolling not only different communities of color, both genders in just about equal ways, and all sorts of age groups. And then they really tried to enroll groups of people with pre-existing conditions. So it wasn't just vaccinations in healthy people and adults. I thought that was really, really great, because then that gave you a much better sense of, a large proportion of our population that have coexisting conditions. Up to today, we have vaccinated about 72 million people. We've given 72 vaccinations in the United States. So I'm going to do a quick overview of science. Stay with me. I think the important reason I want to do this is because there are so many myths about what is being injected into each of us. And I just want to kind of go over a very basic overview of science of this vaccine. So it helps you understand and make the decision for yourself and your family about the vaccine. There's a lot of people talking about people injecting genetic code that's going to change the way our bodies, function, and that there's live COVID virus in the vaccine. And so I really want to dispel and counter those myths, because they are myths, and I want to explain to you exactly what you're getting in the vaccine. So we all know about DNA and RNA, and maybe we don't understand what they are, and I'm going to make it as simple as I can. DNA is essentially the genetic code of our body. So it's like the blueprint. If you're an architect, it's the blueprint of the building. It tells you exactly what the building is made up of. And if you look at any part of that blueprint, you will know what that part of the body is like. RNA is kind of like the thing that reads the blueprint. It holds the instructions. So DNA has the code. Somebody's got to decipher it, right? And so that's what RNA does. And then it shoots out the instructions. So what the COVID vaccine that we have approved in the States right now, they're both RNA, a type of RNA vaccine. And what the vaccine includes is essentially a set of instructions. And these instructions, all they do is they tell a cell to make One single thing. That's it. This entire scientific miracle is basically telling our cells, which we have so many, but it tells them to make one thing. It's one message, and all it is doing is telling it to make a protein called the spike protein. The spike protein is this protein that's on the outer layer of the coronavirus, and it's how it basically enters cells. But the vaccine does not have any viral particle. All it has is a protein. It's called the spike protein. So that protein can't then make more viruses or make DNA or anything. That's it. It's just like a protein that's just floating in your blood. And what the vaccine does is tell your cells, please just make more spike protein. And all of a sudden, your mRNA is like, here are the instructions, and you read the instructions, and then poof, mRNA disappears because you have now made the spike protein. It's kind of like those Mission Impossible movies where Tom Cruise would get like the instructions and then it would burst into, whatever, it would explode, or it would just go away, disappear, magically disappears. And that's what the mRNA does. Once its job of reading the instruction is finished, mRNA goes away, and all you are left with is the spike protein. Now, all of a sudden, your body has this new protein. It's not a part of the body. It is kind of like a foreign element. And the body's like, whoa, 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 what is this? Human bodies' immune systems are meant to recognize things that are natural to it and things that are not natural to it. And when something comes in that appears that is outside of its body's natural function, what do? We make our soldiers, like we talked about. So these are antibodies. All of a sudden, our body's like, okay, time to make our soldiers. And we start to mount a defense against these little proteins that all they do, they're just going to float around. They won't do anything to us. They can't cause disease. They are not going to make us have a cold. They won't make us have a fever. Nothing. They're just floating around, a little part of a protein. So now the body has mounted the defense, and it's amazing. Like I said before, not only does it make the soldiers, it makes the memory cells. And now your body is ready anytime it's ever exposed to a spike protein. So the only other time now it would ever be exposed to a spike protein is if you get COVID infection. Now you've actually got COVID virus in your body because you were exposed to somebody that had COVID or in a room that was poorly ventilated. Now you've got COVID virus in you, but your body's like, that's cool. I recognize you. I don't recognize all of you, but I sure do recognize that protein on you. And that's enough. Now I know I need to fight anything that has a protein on it. What is the protein on? It's on the virus. And so our body will fight it. And that is the most amazing part of this vaccine, that in a very short time, we were able to find what we needed to do to stop the virus from replicating, from reproducing itself inside the body and making us sick. There isn't that much in the vaccine. It's a very simple. It's not like our usual vaccines with there's no preservative, there's no dye. It literally is the mRNA. It's enveloped in like kind of like a type of fat of our that makes it easy to like slip into our cells. That's it. That's part of the reason that like as soon as you pierce a vial, you have a set amount of time to administer the vaccine because there's no preservative. So if you pierce the vial and 10 hours go by, it is no longer a valid vaccine. You can't inject that. So that's why there's this time limit, and people are scrambling a lot of times at the end to get vaccines into arms, because once you pierce the vial, the clock starts. Some of the side effects that many people have talked about, and these are the most common ones, are mostly pain, redness, or swelling at the site, and then fever, fatigue, headache, muscle pain, chills. These are just some of the things you'll see. The most important thing for you to know about that is that side effects are usually really limited to a short time. You can get it with either the first dose or the second dose, or neither, or both. It's unclear why some people have a reaction and why some people don't. Don't freak out if you do get a vaccine and don't have any sort of side effect. Don't worry, you got the vaccine. You're just one of the lucky ones that didn't have a reaction. Um, and then the timing, we know you need 2 shots. Pfizer is 3 weeks between the first and second shot. Moderna is a month between the first and second shot. Um, you do want to get both shots to get the most protection, and we want you to get the second shot as close to the time interval that they're recommending as possible. You don't want to be too you don't want to get it earlier, but a little bit later would be fine, but you want to get it as close to what's recommended as possible. Who shouldn't get the vaccine? So we do know that these research studies were not done on pregnant or breastfeeding women. However, most healthcare professionals do recommend the vaccine for pregnant and breastfeeding women, but we will always tell you that this is a blanket recommendation, but every single individual that is pregnant and or breastfeeding should discuss with their doctor their specific criteria and their specific needs, because there may be things we don't know. But in general, overall, healthcare professionals do not think it's a contraindication to the vaccine if you are pregnant and or breastfeeding. Having said that, we are not giving vaccine to anybody below 16 years of age. There are currently trials both by Pfizer and Moderna to test the vaccine on children from 12 years of age to 16. And as soon as that round goes, they will start to get the vaccine trials in younger and younger children. But currently, there is no vaccine approved for any child below the age of 16. Should I get the vaccine if I've had COVID infection? And the answer is definitely. The critical part to this is when you had infection. So if you are currently isolating at home because you have COVID-19 infection, and this is your 10-day of isolation or 14 days, depending on who you are, that is not the time to get the vaccine. But after that, after your isolation period is over, when it is your shot, when it's your turn, we do recommend that you get the vaccination because reinfection is possible. Anybody that has COVID-19 infection or disease will get some natural protection and immunity. We just don't know how long that protection lasts. So we always recommend the vaccine, even if you've had the infection. Some people talk about waiting 90 days, and that came about because there was very limited information that we could find on people getting reinfected within 90 days of having the COVID-19 infection. But in general, when it's your turn, I would highly recommend getting the COVID vaccine as long as you're not in isolation. So I got the COVID vaccine. Now what? Can't we throw our masks away and go back to life like we remember it, and have our friends over and things like that? And I think the critical message here is that we know, based on the data we have so far, and now we have months and months, we have 6 to 9 months of data to talk about with this. So we do know the vaccine will prevent disease, right? We know it'll prevent COVID disease, which is so amazing. But does it prevent infection? And to reiterate, infection means you could have virus in your body, you just don't show any symptoms. And that's the problem. We don't know the answer to that question. We think you could still maybe carry COVID virus inside your body. And what happens if you're carrying COVID virus inside your body is that you can then, of course, spread it to others, especially others that are not vaccinated, high risk. And then this again pushes a higher potential for mutations because we're still having infection going around. So I just want you to keep that in mind, that just because you got the vaccine, we are still recommending safe 6, at least for now. This may change as more and more people get vaccinated, but in our current day to day, we do not have enough people vaccinated. We do not have enough people that have natural immunity because they were COVID infected. And so outside of your bubble, I don't know that that much is going to change yet. There are people that talk about, can't we have close encounters with people that are vaccinated already, fully vaccinated? And fully vaccinated means you've had both of your shots in the time frame that is recommended, and it's 2 weeks after your second shot. So it's 2 weeks after your second shot that you are now thought to be fully immune. So the question of whether or not you can hang out with other people that are fully immune after their 2 weeks post second vaccine is that, I think that that's a reasonable approach, unless you have people in your bubble that don't have the vaccine, like your children, or you have other people that won't get the vaccine, and you are living with them, and so that's the kind of thing you have to think about. You have to weigh each of these situations and the risk, and benefits. If you don't have any children, you don't have exposure to anybody with risk factors, and everybody around you is vaccinated, well, that's a different question, and we can talk about that. Vaccine hesitancy. So, they did a whole bunch of surveys, and it talked about that that it was about 60% of adults, 50 to 80-year-olds, that said they'd get vaccinated. But that meant 40% said no. And that's obviously not going to get herd immunity if we only get 60% of that group, right? Because that's not everybody. It turns out that women, people of color, people between 50 to 64, and those with lower income education were less likely to say they'd seek vaccination in general. And only 40% of older adults who are Black and 51% of those who are Hispanic said they are somewhat or very likely to get vaccinated. So, despite what we've clearly talked about, the greater risk for a lot of these populations for hospitalization and death, if they do develop COVID-19. And it's very understandable why there is vaccine hesitancy for many of these groups. Building trust in the medical community has a long saga, especially by the Black community. There's a long history of medical mistreatment. Some people would say, oh, the vaccines were developed way too quickly. There can't be any way that they're good, when normally vaccines take years and years of development. And then there's the conspiracy theorists that talk about COVID-19 not being real. So I think the way I approach a lot of this is to, like, clearly there are a lot of medical professionals, specifically medical professionals of color, that are trying to get out into their community, that are getting vaccinated publicly, that are speaking about their vaccination experience and trying to spread the message, especially when we realize how these communities of color are so at such higher risk. The idea of vaccines developing too quickly. The story that I like to use is to think about a skyscraper that needs to be built, and what happens when you throw a lot of people and a lot of money. How quickly will that skyscraper go up? Same idea. If you need a vaccine, you throw a lot of people, a lot of smart people, a lot of money at it, how quickly will that happen? So if you had 6 contractors and each of them were doing one bid to build a skyscraper, that could take 6 to 12 months just for one of those companies to build a skyscraper. But instead, you tell the 6 companies, all of you work together, we'll pay all of you, and you build a skyscraper. That's going to take 1 to 2 months, because everybody's working together and there's money flowing, and there's no problem with, like, just pushing everything quicker because you've got more resources and more people. That was Operation Warp Speed, and that's really what happened with the vaccine. I trust the trials. They had all the phase trials that they're supposed to, the phase 1, phase 2, and phase 3 for each of the vaccines that are currently approved, so that we knew that the vaccine did what it said it would do, that it was safe, and that it was efficacious. That means if it was effective against prevention of disease and infection. And then for conspiracy theorists, I mean, this is a harder one for us. I would say this is one of the hardest parts about what healthcare professionals are going through right now, is dealing with a lot of the conspiracy theories and the anti-mask population. It's hard because what we see is so different than what most people see in their day to day, what we see in the hospital, in our urgent cares, in our emergency rooms. It's heartbreaking, it's crushing, it is devastating. So that can be a really hard thing for us. And I'm going to end with the slide about equity and thinking about, like, we do know communities of color are disproportionately affected. Should our solution target the communities that are more at risk? And should we be thinking about it in that way more? How do we overcome systemic issues that are leading to making these communities more vulnerable? We know older communities are really vulnerable. What about the issues they face with lack of access to technology or ideas of how to use it? They don't have a lot of support networks, and that hinders the efforts to reach them and get them vaccinated. And finally, children will be the last to be vaccinated. How do we ensure that they are protected? So these are all just questions that continue to be important ones for all of us to think of as we go forward. And I'll just end here and just say, this has been obviously a really, really tough year for everyone, the whole world. And, in our lifetime, we've never faced something where the whole world is going through the same thing in different ways, but it's incredible. And as a healthcare worker, it was probably one of the hardest challenges to have so much doubt placed on science during this time, where science was going to be the thing that really saved a lot of us. So I look forward to a time where we believe again. I'm a huge believer in asking questions, but I think that I really do hope that we move forward, progress, and we have beautiful light coming for all of us soon. Thank you so much.
Thank you so much. That was incredibly informative and helpful and comprehensive. So thank you. Good evening, everyone. I'm Jennifer Pear. I'm the Chief Early Learning Officer here at Kidango. And we're just very fortunate to have Tina with us and to benefit from her expertise. And she's not leaving us just yet. She will answer questions. But before we dive into the Q&A portion, I know you have questions. I see one already. We have Julia Nazareto, who's regional director for us here at Kidango, and she was recently vaccinated and has agreed to be here tonight to take just a few minutes and share her experience. And then we will come back and have questions with Tina. So Julia, if you're ready, take it away.
Thank you, Jennifer. Thank you, Jennifer. Hi, everyone. Very proud that I was vaccinated along with two of my team members from Washington Hospital. Couple weeks ago, we got our first dose of the COVID-19 vaccine. The process was very smooth. We came into our room, we got our card, and we were assisted by a couple of nurses in the hospital. We got our shot, and of course, it was very nerve-wracking, very nervous. This is a big thing for us, for our community. And we sat down, we gave our card, we got vaccinated. It was very quick, very fast. After the vaccine, we were asked to wait for about 15 minutes just to make sure that there's no other side effects or any just to make sure that we're okay. They checked us a few times, and then after 15 minutes, that was the only time we were allowed to leave. I did not get any side effects aside from a sore arm, but I feel great and excited to get my second dose next week. So I'm excited and hoping that a lot of our families and our community get vaccinated soon. So thank you, Tina, for your presentation.
Thank you so much, Julia. And here in Alameda County in the Bay Area, fortunately, we've been able to expand the pool of eligible people who are eligible to get the vaccine. So we're now in what's called Tier 1B, which means that teachers and childcare workers like Julia can be vaccinated. So that's really exciting. We're making progress, and there is definitely light at the end of the tunnel. So reason to be hopeful and optimistic. And I see one question here. If there are other questions, you can put them in the Q&A box. And I think at this point, Andrea, am I going to hand it back to you, I think, to facilitate some questions? Great. Thank you.
You've got it. Thank you, Jenna, and thank you, Julia, for sharing your experience. So we'll go ahead and start with the Q&A. If we don't get to your question by the end of today, we will put a link up on the screen where you can ask questions, and your answer will be sure to get you an answer to your specific question. So we can go ahead and get started with questions now, see how many we can get through. And before we end, we'll make sure to offer an opportunity for the questions that we don't get to be answered at a later time. So we have our first question, and you touched a little bit on this already, Dr. Sebastian. The question is, how is it that the vaccine was created so quickly when we have other things such as cancer that do not yet have a cure? And what about in the future? How will this vaccine affect people down the road? Is it possible that it can cause something else later in life?
Yeah, thanks for the question. I mean, for the first part of the question, like I said, I find it incredible what happens when you throw a lot of money and resources on something. And Operation Warp Speed was that. It was this private-public partnership from the government with some private entities like Pfizer and Moderna. And it threw a lot of resources in. So like I said, it was that idea of like 6 contractors building, one skyscraper each versus 6 building just one. So I have full faith in the process it took for the vaccines to be produced and to be tested. In terms of thinking about what will happen in the future, I mean, that is one of the hardest questions to answer. We're still so new to this. These vaccines, they haven't even been around a year. Like it's been such a short time period. So I can understand hesitancy about not knowing long-term effects. Most of the time, for most vaccines, we tend to see the majority of effects within the first 6 months. And we have had 30,000 plus participants that have already had the vaccine for at least, I would say, 3 to 6 months at this point, and a significant portion have had it past 6 months. So I feel like we have a good sense of this short-term risk, which is going to have the vast majority of reactions for vaccinated populations. But really, really long-term, that does remain to be seen.
Great, thank you for that. And the next question is, how long does immunity last after receiving the second dose?
Yeah, also great question. That's nobody has a exact answer to that as well. This is one of the issues with novel viruses. So I think the general consensus is that you will have immunity for months, the vast majority of people. Does that mean 3 months? Does that mean 6 months? Does that mean 9 months? That remains to be seen. Most people do believe that this may become very similar to a seasonal flu vaccine, and you will have a seasonal COVID vaccine. That also remains to be seen. I think the first step is trying to get it under control. Like I said, mutations are very common. We have mutations in the flu vaccine. That's something we see every year. And as people have gotten used to seeing the flu vaccine, it affects less and less people. It doesn't become as frequently a pandemic. We have pandemics with flu sometimes, but this being brand spanking new, like that we've never seen before, it does create a lot of unknown territory. So I would say that for now, you get your vaccine when it's your turn. We hope that this vaccination this vaccination will give us immunity for hopefully at least to the minimum till this fall, if not longer. And then we go from there. But we have to get people vaccinated to stop the pandemic. We can't get anywhere without the pandemic getting like a strong stop.
Thank you. Another question that we have is, when do you think that our children will be able to get vaccinated?
Yeah, that's another great question. I think that it may be in phases. I do believe that our teens, our 12 and above, will hopefully get vaccinated by the summer. That's I think a very strong possibility. The studies have not started yet on children younger than that. Not yet. So the good news though is that for phase 3 trials, which means when they're trying to give vaccines to this enormous group of population, you need 30,000 at a minimum of participants. Okay. Like I think Moderna had 40,000, if I'm not mistaken, but you don't need that many children. So that's really a great thing. Your numbers of children that need to be enrolled in these trials are much, much fewer. I mean, some of these trials, you could have like 3,000 children. So that means that it could be faster. It won't take as long as an enrollment of 30,000 adults. So, if you listen to Dr. Anthony Fauci, he would tell you that by the end of this year, he expects most children to have the vaccine. Let's go with that. I think that's a reasonable thing. I think it's hopeful. I think that's the way it looks like it's going. Science seems to be moving that way, and we have no reason at this moment to think it won't happen.
Great, thank you. Now, another question that I've heard, it's not one that's in the box, but another one that I've heard is that there are some pretty significant long-term effects after having gotten COVID. One, is that true? And two, do you know if the secondary effects that you may get as a result of COVID could be long-lasting?
Yeah, great question. Thank you for that. So there are some studies out there that talk, and most of these are done in adults, that say that up to 30 to 40% of adults that had COVID infection 3 to 6 months later continue to have symptoms. A lot of those symptoms would be things like fatigue, some intermittent chest pain, joint pains, headaches. So many people would be like, well, that doesn't seem like that big a deal. We're not talking like you can't breathe or your heart's not functioning right. But I guess you can take that as you will, but I would have you think about what it would feel like to function as a working adult that continues to experience chronic fatigue, chronic body pain, constant headaches. How do you function? How do you earn a living? How do you take care of your family? And so I think there is a significant portion with that level of side effect. There are also what we call the long haulers that have a much more complicated medical clinical history. They continue to have a lot of problems with their breathing because their lungs have gotten scarred. The heart has been affected in a lot of people, even healthy people, even young, like 20s and 30-year-olds. I mean, we've never seen anything like this happen in our lifetime, to be honest with you. It blows our minds to see healthy 30-year-olds that are in the ICU, need a breathing tube. And then when they recover, they're like, they can't walk 10 steps without feeling short of breath. And that's 3 months later, they continue to need oxygen. They can't work. Again, these are not as common. So I told you the 30 to 40%, that's more common. But I don't want you to think that it's not happening. And the studies on how many are having the more serious effects, that's much lower. We're talking, 5% or less having the really, really serious effects, but it's going on. And then in children, as I said before, we're having so many mild to asymptomatic disease. But for some reason, this MISC is hitting hard, and it's hitting hard now, which is really scary to a lot of us. Given you have to remember my bias, I work in an urgent care, so I'm seeing the sickest kids, right? I mean, we're not an emergency room, but our community treats us like an emergency room. So in my mind, I see a lot of sick kids, but the vast majority of kids don't get sick. So it's a bias that I want to make sure I let you know, so you're aware that I see a lot of sickness. That doesn't mean that's what's happening in general out there.
Great, thank you for that clarification. Now, we have a few questions that are more related to our process and our policy. So I want to just save some time for that, given that we don't have other questions now, but I also want to open it up. Jen or Julia, are there any questions that you have gotten from parents in regards to the vaccine or to COVID that you can ask now?
Yeah, one question I had is, what's the current thinking about how frequently people will need to be vaccinated? Do you think it's going to be like an annual, like the flu shot?
Yeah, I do. I do. I think that we're going to be seeing a lot of variants pop up. So I think that as we expect with any viral illness and any virus, and so I do think that. I think that we may also need to prepare our communities for a booster shot even within this year. So there's been some talk about that, especially if some of the more stronger variants take hold in the United States. As of now, Pfizer and Moderna vaccines have shown great efficacy against the variants, and hopefully that will continue. But like I said, if we don't get the pandemic under control, we're just gonna get more variants, which means that the likelihood that the current vaccine we have as being as effective does go down. So we're just trying to battle that at this point. So.
Thank you. Thank you. And I had one other question, if I could get this one in. I really appreciate that you took the time to talk about vaccine hesitancy, because I think that's a reality in our communities. And just wondering, I mean, certainly presentations like tonight and tonight's meeting is an important way to get information out to everyone and help people feel more comfortable and confident about the vaccine. But do you have any other suggestions or recommendations for ways that we can help with that and help our families and our staff who might be, feeling unsure, to feel more comfortable?
Yeah, it's a great question, and it's definitely a challenge. I think having someone like Julia talking is super important, because she is a well-known part of Kidango, and there's a lot of trust of the community with her, as opposed to me. I'm a stranger. Like, even if I am, anyway, but so that's a big deal. What we've done in Colorado is we have tried to have vaccine mobile clinics kind of going into the communities, and then the people administering the vaccine are people of the community or look like the community, which I think is a really important part to this. I think the messaging has to come from people that the community trusts. So we've been doing that with flu vaccine even before COVID, and so the idea that we would be going out to the communities to do this is not new. And I think the other side of it is that the more the time passes, that people who know a person that got the vaccine and the person is still okay, I think that also helps. Having said that, like, I'm not trying to delay people getting the vaccine. I'm obviously really pushing as much as I can to have as many people vaccinated. But I think that helps. I've had a lot of friends, professionals, say to me, I'll get the vaccine, but I won't be the first. And even if it's my turn, I'm still probably going to wait for that next, like, I'll continue to do all my precautions. I'm okay right now doing my precautions. So I think it's to each family and to each individual how they, approach it. I would never obviously insist on anybody not being comfortable. This is a hard decision. Nothing can about this can be mandatory at all. So
Thank you so much. That's helpful and good suggestions.
We do have another question. After getting vaccinated and being fully vaccinated, is it okay to, should we still double mask, or are we okay to just wear a single mask?
yeah, that was a new recommendation by the CDC that doubling your mask is more effective. And part of that I think was because some of the variants were so much more contagious. So already coronavirus was pretty contagious. And then you had these variants that were even more contagious. So there was a suggestion about the double masking. I would suggest to you that, um, you know, you should continue all your prevention as much as you can if you are going to be around anybody that is not going to be vaccinated or vulnerable. So I have no problem double masking. Some people definitely hate double masking. So I wouldn't want to make people go too far, like be like, oh, then I'm just not going to mask at all. To me, a single mask is better than no mask. So I will always say, you do what you need to do to do as much prevention measures as possible. But it's really also critical that, like I talked about in that slide about now I have the vaccine, can I go back to everything being normal? I mean, again, that decision is going to be all about who you are around and who you are exposed to. So that's how I would answer that risk question.
Thank you. The next question is, when you get the first vaccine dose, does the second vaccine have to be from the same company or not?
Yeah, that's a great question. Thank you. Definitely. And the reason being that the studies that were done, all the research we have is based on that protocol. So Moderna has its study from studying their vaccine given, twice with a month apart. Pfizer has their studies done with just, so there's been no evaluation, no study about somebody who got a Pfizer one and then a Moderna one and what that means. And that's definitely not what we would recommend. We would not, because we couldn't tell you anything about efficacy and what that means for future immunity.
Great, thank you. The next question is, I'm wondering, will there be any consequences to breathing our own air since we wear the mask for at least 8 hours?
So meaning like the air that we expel, is there risk to us, or are we talking about like if we're in a classroom setting? What would you think, Andrea?
I'm thinking it's probably the former.
Okay. Yeah. I mean, no, I think that you're not going to like infect yourself more. Like, let's say you have an asymptomatic infection, you're not going to infect yourself more. So that part, to you, your personal risk, I wouldn't be concerned. The risk is to others.
Great. And I think that brings us to the last of the questions that we have at the moment in regards to, oh, we got one more. If more adults are vaccinated, we are available to have more, will we be able to have more children in the classroom?
If more adults are vaccinated, is that what they said?
Yeah, so I think that's probably both you, Tina, and maybe Jen.
Yeah.
If we were to have more teachers in the classroom, I imagine vaccinated, would we then be able to increase the amount of children in our classrooms?
Right. At the current time, we are not going to change our recommendations about what we think is the ideal prevention in schools. I do. The only caveat I would say to that is that to us as pediatricians and public health professionals, everything to do with school transmission and procedure is linked to what's happening in the community. If you have truly high transmission of COVID in the community, it doesn't matter if a lot of people are vaccinated or not. Like, you have a high proportion of COVID in the community. You have to do the most everything possible to prevent it, even in the classroom, even among those that are vaccinated. If you have super low levels of community transmission, this is why in the summer you saw things like children don't have to be 6 feet apart in the classroom. You could be more like 3 feet apart, as long as you're wearing a mask and as long as you've got, the hand washing and all that. So I want to make sure people understand a lot of the recommendations is based on what's happening at the time. I hope that people don't feel that people are just trying to make it up as we go along, because the summer was different than like the winter, obviously, in terms of that. So that's something to think about. But I do, at this moment, we are not changing any of those recommendations, even among vaccinated populations.
Thank you. So now we have a question for you, Jen, and it's more in regards to our process at Codango within our classrooms. So the question states, it's more for the kids, 2%. Would we be able, or how would we be able to keep our parents accountable for keeping their children home if they are sick? In her case, she says her son's school has 8 children, and all children were sick. It was her son's first week back after a 2-month isolation, and on the second day back, he became ill. Unfortunately, now she is unable to work, and she lives with her parents who are still recovering.
Yeah, I hear your frustration because there's COVID kind of looming over all of us, and we're still technically in flu season, and then there's the common cold. So it's really difficult to kind of distinguish. And we're trying to, err on the side of caution and be really careful. So there's a lot of education, and part of, meetings like this, just reminding people that it's important to stay home if your child is exhibiting any symptoms of illness. It's important that we do our health screening every day at the centers. So, you're getting those questions every morning when you drop off, you're getting the temperature check. We're looking for any signs of illness for the child. And we do the same thing with all of our staff. So we've really put a lot of effort, going on almost a year here of really doing everything we can to protect the environment and to keep children and staff healthy. But I hear you, it's super difficult. And we should have a consistent approach across the board for all of our classrooms. So teachers should be excluding children who don't pass that health screening in the morning and sending children home right away if they become ill at school. And we do ask, if symptoms should crop up during the day or if we have to exclude a child from attending, we do ask them to stay home for 10 days just to be careful. If they can see their healthcare provider and get a note, some kind of confirmation from their healthcare provider that whatever symptoms the child is experiencing is not COVID related, if it's allergies, for example, maybe related to a pre-existing health condition, then we can have the child back to care without going the full 10 days. But I hear you, it's really difficult. It's incredibly hard on families when we have to exclude children. We know our families have to work. That's why they're bringing their kids to us every day. And when you miss work, that's incredibly stressful on you and for your family. So we're constantly trying to find that right balance of not excluding children unnecessarily, but making sure that we're doing everything we can to keep the classroom and all the children and staff protected and safe.
Thank you,
So
Jane.
Yeah.
I'm sorry, go ahead.
Oh no, I was just going to say that's a tough one. It's really hard, and I hear how difficult that is.
And then what I would also like to tell this parent is, as Jen said, we have a process that we've worked really hard on developing and being really thoughtful and mindful about how we do this with the screenings, and that there should be a consistent system and process. And I would say that if you have any questions or concerns around the process not being consistent, if that's your experience, or if you have any specific questions, just strongly encourage you to talk to your center director to seek some clarity and engage in a dialogue.
Right. Thank you, Andrea. That's important. So yeah, if you need to talk with your center director, if you need to talk with your regional director, if you'd like to talk with me, if you have concerns that our policies and procedures are not being applied across the board or as they should be, feel free to reach out. Happy to talk with you.
Great. Thank you, Jen. Another question around our process and our expectations. This one's in Spanish. It says, ¿Querengo va a requerir a los niños que regresen por completo a las clases o van a poder seguir en clase de Zoom? So it's, will Querengo be requiring children to come back to school full time? Or will they have an option of continuing to do remote learning through Zoom?
Yeah, so for the foreseeable future, families have that option. So until the end of this program year, we'll get more direction from the state as far as how our funding is going to work for the next program year. But for now, you have that choice. So if you're not comfortable, returning to the program, you can remain in our distance learning program, no problem. And when you're ready, hopefully we'll have a spot for you in the classroom and you can come back to care.
Thank you. La respuesta para esa pregunta es que por ahorita vamos a seguir el proceso como lo hemos estado siguiendo. Si ahorita su niño o su niña está en casa y está recibiendo la lección así, es como vamos a seguir, de menos por el tiempo que se termina este año el programa. Y ya cuando vayan a cambiar las cosas, eso va a ser una conversación, pero por lo menos ahorita las cosas van a seguir igual. And another question is, I'm wondering if we could get in writing what to do when children are sick with a variety of illnesses or symptoms, just so we are all consistent.
Sure. I know we share a lot of resources from the local public health departments. So there's, tons of information and lots of things in writing of symptoms to look for, isolation periods, quarantine periods. All of that is fairly standard. Might be a little bit different county to county, but we have lots of things in writing and happy to share that with you.
So that was our last question. We have about 7 more minutes left. What I'm going to do is, well, if Tina, if you have anything that you'd like to add before we go into our closing, that would be a great time.
Thank you. No, I'm so grateful to be able to talk to you guys. I hope I was able to answer some of your questions and hopefully clear up any misconceptions or things that you didn't understand super well before. I'm a pediatrician and children are obviously my passion. So it's been an interesting time for us to try to figure out how to help kids the most. And in the early parts of this epidemic in the US, we weren't seeing that many sick kids. It was incredible to see that when we went into lockdown or we went into remote learning, kids weren't even coming in for anything barely. Like, it's incredible. We're twiddling our thumbs, at the urgent care. Very, very few visits. And then what really started coming in was a lot of mental health issues and depression and anxiety, and it's really devastating to see the effects of the epidemic and pandemic on the psychosocial part of children and adults. But I'm going to speak more about the kids. And now that things have opened up, we're obviously seeing the clinical side again and the illnesses too. But I am a big proponent. I'm a huge proponent of getting schools safely open. As I know all of you are, I think that our children really, really need it, especially our youngest. And I look forward to being able to work with different systems and people to try to make that happen. So I applaud all of your efforts. This is not an easy time to be an educator in any form. So thank you so much for your service.
Absolutely. Thank you for being here and for bringing up the mental health piece. As adults, our mental health directly impacts the mental health of those around us, especially children. So as children they have their own mental health that is being impacted, and they're also carrying and being impacted by the mental health of those around them, right? So the real importance of addressing those those negative consequences of times like this. So thank you for making that connection as well. And of course, for taking the time to be here. We know that you could be doing a bunch of other things with your time. So we really just appreciate you being here, especially given the connections that you have with Kidango. Jen, thank you for answering questions and for helping us understand a bit more about our policies. And Julia, thank you for sharing your experience. Very valuable in helping people see what the process is like, and hopefully encouraging more and more to get vaccinated as they are able to. So for those of you who still have questions, or maybe we are done today and you have more questions, Mario, I'm going to ask you, please show the slide with the link to the questionnaire on it. If you have questions, please go to this site, ask the questions that you may have, and we'll make sure to answer your questions directly. So again, thank you all for being here today, for joining us. We hope that you have found this time beneficial, that you have gotten some really great information through the presentation, and that you continue to engage in this process, and remember that it is all of our responsibility to get through this time together. So thank you and have a good night.
Thank you. Thank you, Tina.